Hi, everyone. I hope that you and your families are doing well in this unprecedented time that we are all facing together. Thank you, Erica and Sean, for inviting me to present for the cancer support community. It's always a pleasure, no matter what the format is. My name is Darcy Burbage, and I've been an oncology nurse in Delaware for over 30 years. Before we begin today's presentation, I get this question a lot, so I thought I'd start here by briefly reviewing what doctors are taking into consideration when they recommend treatment for your cancer. They look at established evidence-based guidelines from the National Comprehensive Cancer Network that were determined because of clinical trial results. First of all, you. Everyone is different, and even if you have the same type of cancer as the person sitting next to you in the waiting room, individuals' variables are taken into consideration, such as the stage of cancer, the type, the biology of cancer. All may be different, and your recommended treatment may also be different. It's also not uncommon for us to have other health conditions besides cancer, and your team wants to make sure we look at you as a whole person in order to recommend the best and most appropriate treatment for you. In some instances, multiple regimens exist. In addition, we also look to see if there are any clinical trials that you are eligible for. In cancer care, clinical trials compare standard of care to another regimen, which all lead to potential effects of treatment. Our evolving knowledge of the lingering side effects of cancer treatment has implications as to how you're evaluated in the medical setting and for the delivery of follow-up care and surveillance. Cancer treatments are constantly changing, and as a result, unknown or unanticipated side effects may only become apparent over time. Some individuals experience relatively mild side effects and some very severe. There is also a misbelief that the more side effects you have, it means your treatment is working. That's not the case. As individuals with cancer are living longer and have other health conditions, it may be difficult to tell the difference of cancer treatment effects from other health condition effects. For example, peripheral neuropathy may occur as a result of diabetes and also occurs as a side effect of certain chemotherapy medications. Acute effects of treatment, and I'm talking specifically about chemotherapy here, affects rapidly growing cells. So in addition to cancer cells, which grow quickly, cells in our GI tract, hair follicles, and bone marrow also grow quickly. So this is why if you're receiving chemo, we spend a lot of time educating you about how to manage these effects and signs and symptoms to report to your doctor. Most individuals experience some type of side effects during treatment. However, it's often surprising to some patients that side effects may linger on after treatment is over or can appear later on. Potential effects of treatment encompass not only the physical and psychosocial domains, but also has an economic impact as well. These four categories are the most common types of treatment and their associated side effects. However, it's not all treatment that you may receive, nor is this a comprehensive list of all potential side effects. The other two categories that are missing from this slide are stem cell transplants as well as immunotherapies. For individuals receiving immunotherapy, it's relatively new, and our knowledge is in the early stage of learning the most common adverse effects and how best to manage them. Right now, if you're taking any immunotherapy medications, your treatment team will give you very specific instructions to follow. Most immunotherapy side effects have an inflammatory response to them, so that's also important to know. Stem cell transplants and CAR T-cell therapy deserve their own lecture. So if you have questions about these side effects of this type of treatment, I'm going to refer you back to your treatment team, your doctor or nurse, for more information on those effects of treatment. The first side effect that we're going to talk about is fatigue. Among people with cancer, almost 100% experience fatigue. Fatigue may occur as an isolated problem or occur as one element in a cluster of symptoms such as pain, anemia, and sleep disturbances. Rest doesn't ease fatigue, and it can last for months or longer after treatment is ended. Symptoms of fatigue include a lack of energy, wanting to sleep more, not wanting to do normal activities or being unable to do them, feeling tired after sleeping, or even having difficulty concentrating or trouble thinking. And this is a different kind of fatigue that you may have experienced when you've worked long hours at a job and had to come home and take care of several children and parents and have other responsibilities. This is a really wiped out type of fatigue. Multiple research studies have shown that after treating for underlying conditions, exercise is the most effective treatment in managing fatigue. Walking, yoga, tai chi have all been shown to be effective, and some are available through the cancer support community. Cognitive changes, sometimes called chemo-brain, chemo-frog, or cancer brain, occurs in about 80% of individuals treated for cancer. As we know, it also occurs in patients who have not received chemotherapy, so that's why I like to call it cognitive changes. The diagnosis of cancer and the associated stress and anxiety that occur as a result of a cancer diagnosis can also cause changes in memories. Patients describe feeling more forgetful, having trouble concentrating, or losing attention more easily. For some, different treatments of side effects may also cause cognitive changes. Let me just assure you that this is real. Some practical things that you can do to help minimize these cognitive changes are trying to keep a routine, write things down, exercise your brain by doing puzzles or games or reading, along with bringing someone with you to appointments are also very helpful. Another common side effect that we see as a result of chemotherapy is called chemo-induced peripheral neuropathy. Certain types of chemotherapy increases the risk of CIPN, which are the taxanes. Usually that's either Taxol or paclitaxel, some platinum-based medications, carboplatin, oxyplatin, cisplatin, as well as vinca medications such as vincristine. Individuals who also have additional medical conditions, as I mentioned earlier, such as diabetes, or if you have fibromyalgia, poor circulation, a pinched nerve, or herniated disc, may also intensify the neuropathy that is associated with chemotherapy. In my practice, most often chemotherapy medications are given in combination, and we see that the taxane-based medications cause neuropathy to occur within the first few doses, and the platinum-based medications tend to cause neuropathy after chemotherapy has been completed. Most chemo drugs that cause neuropathy do so with a length-dependent distal glove and stocking distribution, meaning that the neuropathy affects their toes, feet first, then travels or extend upwards. Neuropathies related to chemotherapy can last up to a year after treatment is completed, and in some cases, neuropathy may plateau. Patients with cancer describe neuropathy in many different ways. For example, some of my patients have shared with me words to describe how they're feeling, such as causing numbness, tingling, feels like their skin is crawling, weakness, losing balance. Some complain that they have a hard time buttoning their shirts, difficulty holding a pen or other objects, having extreme sensitivity to cold or heat, feeling like you're walking on marbles or eggshells, or feeling like you're wearing some sort of gloves or stockings even if your skin is bare, or even just, Darcy, I have a really weird feeling in my fingers and toes. In severe instances, I have patients that have experienced pain from usually non-painful stimuli, such as bed sheets, or attempting to wear clothing items such as socks or shoes or gloves can really cause some significant pain. Unfortunately, there's not a way to currently prevent a neuropathy from occurring. Being aware of chemo-induced neuropathy is the best way to get treatment early. Um, in some centers, physical and occupational therapists offer free educational classes in addition to the education provided by your oncology nurse. Prehabilitation is another service that a lot of cancer centers are offering to teach specific exercises and safety measures such as fall prevention tips, wearing sturdy shoes, moving space rugs, in an attempt to empower patients to proactively manage neuropathy. Currently, the only medicine that's found to be effective is Cymbalta. Other medications such as Neurontin or Lyrica are also used, and it's been shown to change the way that the body senses pain, so it's not exclusively used for peripheral neuropathy. Some patients use the B vitamins or vitamin D. However, to my knowledge, there hasn't been any studies evaluating a specific dosage or those medications as a preventive measure or treatment for neuropathy. Um, if I have patients that ask me about this, usually our oncologists advocate for one multivitamin a day, not mega doses of other types of vitamin. Research is also looking at cold therapy, also called cryotherapy. Some people are using ice gloves or ice socks to help reduce the incidence of neuropathy from occurring. So I haven't heard if the exact jury has been back yet in regards to that. So use it with caution and also ask your doctor if that is acceptable to use while you're receiving chemotherapy in an effort to help reduce neuropathy from occurring. Some types of chemotherapy can also cause your skin to become dry, itchy, red, or darker, and in some instances may peel. You may develop a minor rash or sunburn easy and become more sensitive to the sun. Sometimes it's called photosensitivity. Some people also have changes in your skin pigment. Nails may also become dry, dark, and cracked, and your cuticles may become painful. If you received radiation therapy in the past, the area where you received radiation may become red, blister, peel, or hurt. This is called radiation recall reaction. There's a skin condition known as hand-foot syndrome that occurs as a result of chemotherapy administration and usually occurs, or not usually, but most commonly occurs for patients who are receiving doxorubicin or adriamycin or capecitabine, also called Xeloda. And there's also some immunotherapies that may also cause skin changes as well. So these are just some suggestions on this slide, but certainly talk to your doctor about anything more specific than that if you are experiencing any of the skin changes. If you are receiving radiation therapy, skin changes are not uncommon in the area that you're getting treated, and it's recommended that you bathe or shower using tepid water, a mild soap, and just pat dry the area. There's also some creams that could be recommended, and usually in sequential. So we try with something a little bit more milder than go up to something prescription if needed. Nail changes occur as a result of certain chemotherapy medications as well, where the nail becomes thin, brittle, or dry, and in some cases develop lines or ridges that correlate with the number of chemocycles that you give. Sometimes the nail separates from the nail plate. It may fall off and infections may occur. If you have lymphedema, a nail infection can make it worse. Some management strategies to help with nail changes are to keep your nails short, clean and trimmed. Avoid professional manicures and artificial nails. Um, you want to keep your nails painted to increase nail strength. Just with a clear polish you can use, or if you like a color, certainly, but use a non-acetone remover. You don't want to cut your cuticles. You want to use a cuticle cream or gel, and also wear gloves if you're doing anything outside or in the garden just to protect your nails. In addition to the physical challenges that a diagnosis of cancer can bring, the psychosocial effects of cancer treatment can be equally as stressful. I hear from my patients fear of recurrence around the time of a scan, or time of a doctor's visit, or a time when an anniversary occurs, such as when you receive the diagnosis or when that first treatment started, or for individuals who've completed treatment for cancer, also complain of fear of recurrence. And one individual shared with me that he calls it the psychological hangover. So on the slide that you'll see here are some other psychosocial effects of cancer. In a survey by Livestrong, 80% of cancer survivors indicated that fear of recurrence is their number one concern, followed by sadness, depression, low energy or sleep disturbances, as well as financial concerns. Debt incurred as a result of cancer treatment, reduced income, outstanding medical bills, losing your job, as well as concerns regarding health and life insurance. Psychosocial adjustments to life after cancer treatment can range from trouble concentrating to losing an interest in what you used to enjoy, including a survivor's guilt. Why am I doing so well when the person I met and became a friend during treatment, we sat next to each other when we received our chemo, isn't doing as well? So guilt can also occur, as well as a post-traumatic stress disorder. So it's important to take care of your emotional health as well. However, the good news is that positive changes can and do occur. I've had individuals that have had cancer share with me that it made them appreciate life, help them make positive lifestyle changes, renewed their sense of purpose, and help them establish perhaps even something new to do. Ask themselves, am I living the life that I want to lead? Helping you not sweat the small stuff. So there are people that make, dramatic life-altering decisions. Not many, but certainly some do. However, most of the time it's subtle, conscious, personal choices that only you know. Some strategies to help manage psychosocial concerns are to rely on trustworthy sources of information, your treatment team, your doctors, your nurses, your support group leaders, talking with supportive friends and family, joining a support group, or perhaps even seeking individual counseling, or all of the above. Revisiting your spirituality and whatever that means to you, if it's reconnecting with a formal group, or perhaps it's meditation or spending more times out in nature, asking for and accepting help. We're not super people, so it's good to ask for help and accept it. People are wanting to help you. Learning how to set boundaries. Perhaps you don't have to go to, a 6-hour conference or party or event. Maybe it's going for an hour or so. Learning new ways of coping, if it's journaling, if it's meditating, however that you want to approach that. Giving back by helping others through volunteer programs. It doesn't necessarily mean through a volunteer program to help other individuals with cancer. But say you always wanted to help out with a craft camp or something like that, something that you want to do just to give back, reconnect, and just have some fun, get out of your head for a little while. So those are all important things that you can do to help manage these concerns that may also occur. So I just want to switch gears a little bit. In addition to being aware of and in management of the adverse effects of treatment, there are additional programs that are very helpful that can help you manage these effects. Early on in my career in cancer care, rehabilitation was the only option that was available. Now we know prehabilitation, meaning that if we begin rehab early between the time of a cancer diagnosis and beginning of treatment, perhaps we can reduce the incidence and severity of future impairments. So that's a new way of thinking, is having prehabilitation to help condition you so you can tolerate treatment better rather than starting after treatment has been completed and getting you back to the function that you have had at the beginning, or to a point where it's better than it was after treatment. Some examples are, for different types of cancer that I included on the slide here. It's not, necessarily an exhaustive list, just a few. For individuals who are now living with an ostomy, there are ostomy nurses that are available to help as well. And as you can see, it's not all physical exercises that we're offering. Psychosocial support are also important, nutrition, counseling, as well as smoking cessation strategies if necessary. So they're all included. Mind, body, spirit are all part of wanting to provide you the best possible care that we can. Another valuable resource is supportive and palliative care. Supportive and palliative care is helpful and very valuable for patients with any stage and type of cancer. However, the perception is that supportive and palliative care is the same as end-of-life care or beginning of hospice care, and that is not the case at all. Supportive and palliative care team are symptom management experts. They are an additional resource for you, for your care partners, as well as the oncology team to help manage side effects related to treatment. Yes, they certainly help with discussing goals of care, as well as helping facilitate difficult conversations, but that's not the only thing that they do. And we're very fortunate that there's a supportive and palliative care program in each county in Delaware associated with a lot of the major health institutions that are there. And another effect of cancer treatment that I would like to discuss that can be equally as distressing as any physical or psychosocial symptom is financial toxicity. The economic burden and growing cost of cancer treatment has steadily increased in recent years and continues to increase with newer treatments such as immunotherapy, as well as the ongoing costs associated with maintenance therapy. In addition to the cost of the cancer treatment itself, living expenses are also impacted by the cost of cancer treatment, such as your mortgage or rent, transportation, including gas, bus money, money for food, utilities, as well as for child or elder care. Oftentimes, and I hear this from my patients as well as their family members, that they can't take off work because they need to pay for treatment and are working for insurance or working despite having fatigue or neuropathy or some of the other side effects that we discussed. Long-term regimens are also likely to exacerbate the problem of financial distress, particularly in the cases of individuals who are receiving endocrine therapy, maintenance therapies, or those living with recurrent or metastatic cancer. And having insurance doesn't exempt us from financial distress. Individuals from all insurance levels or non-insurance levels experience this because of the high out-of-pocket expenses such as deductibles, co-pays, DMEs, which are the durable medical equipment, such as you need a walker or other equipment. Um, Even people with insurance are surprised by what their insurance plan doesn't cost. If you have concerns about your finances undergoing treatment, social workers are a absolutely great resource to help you manage these concerns. Additionally, cancer-specific advocacy organizations such as the Leukemia Lymphoma Society, um, Delaware Breast Cancer Coalition, as well as other cancer-specific organization, as well as through the cancer support community, may have some resources to help you as well. So certainly, please ask. What I also want to stress is it's important to understand your insurance policy. And most insurance companies, private insurance as well as Medicare and Medicaid, have case managers that are available that you can ask to help you explain things. They're also a good person to know just in case you need pre-authorization or pre-certification for procedures, as sometimes that occurs. And it's helpful to know who the case manager is that's responsible for your policy and also to help you. It's also important to keep track of everything. You'll get explanation of benefits called an EOB, which is not a bill. It just explains what your insurance covers and what you may be responsible for, as well as the actual bills. You also may want to ask your social worker or nurse navigator, financial navigator, if you're eligible for any assistance programs, or if there's an opportunity to consolidate bills, or if you can set up a payment plan. So don't be afraid or embarrassed to ask these questions because they are affecting many people. So, and that's what we're here for, is to help you get through this. And the next few slides, I just wanted to put up some common insurance terms. Learning the language of cancer is a whole new language, and now, probably more than ever, you're learning about different insurance policies and what different terminologies mean. And I just want to let you know, if I haven't said this already, that a copy of these slides, Erica has. So if anyone is interested, you are certainly can ask for a copy of them that you can have for your own knowledge and keep with you. So these are some common terms that you may hear of. Or if you're on Medicare, they come with their all new set of terms, such as what Medicare A and B means. What is Medicare C? Medicare D is the prescription drug plan. So these are all new languages that we're all required to learn. Also, some more Medicare terminology that you may hear if you happen to be on Medicare or getting near the age of applying for Medicare, or if you have a loved one that is nearing the age or are currently on Medicare. So these are some things that you may hear. And finally, I just want to begin to talk a little bit about health promotion and surveillance. For some of you listening today, I recognize that you may be living with recurrent or metastatic cancer. So some of this information may not apply to you relating to the frequency of follow-up visits and testings, but certainly implementing any lifestyle choices, as well as the importance of reporting any new or persistent symptoms, certainly do. For those individuals who have completed active treatment for your cancer, the purpose of the follow-up care includes monitoring for any long-term or late effects of treatment, helping you cope with the side effects of treatment, as well as watching for any signs of recurrence. Keep in mind, every person treated for cancer is different. We also may want to update your family history For example, if some other individuals in your family were diagnosed with cancer, maybe genetic counseling and testing would be an option for you at this time if it hasn't been done before because of that change in family history. And as some patients have described to me, when treatment is over, they also feel that it is just as challenging as beginning to live this new reality. I try to steer away from the term as new normal because there is nothing normal about living with a cancer diagnosis. So I like to say a new reality. So please keep in mind if you develop any new symptoms or have one that doesn't go away in a week or one that's not resolved by your usual routine, it's important to call your doctor. Not all symptoms mean that it's cancer or cancer has come back or it's spread, but we want you to keep us updated if there's something that, I always call it a gut check. If there's something that's not setting quite right, is to call your doctor. And I know sometimes it's not uncommon to have many doctors involved with your care, not only your primary care provider, but your primary oncologist, or if you've received radiation therapy and have a surgeon. So you may have many doctors that are involved with your care, and sometimes it's hard to know who to contact or who the best person it is to contact. If you have access to a nurse navigator, I would suggest call him or her, discuss what your symptoms are, and they can kind of navigate you to the best provider to help manage that side effect or symptom, or to get in for an appointment. What's also important is to continue with regular medical and dental screenings. It's important to have your mammograms, colonoscopies as indicated. Get your cholesterol checked as you should. Make sure that we monitor your blood pressure, that you're eating healthy, that you're exercising, that you stop using tobacco products, wear sunscreen if you're outside, as well as taking care of yourselves emotionally, as we've talked about. So in summary, you are the most important member of your healthcare team. And I want to stress that your healthcare team works for you. You are not bothering us if you call us. We're here to help you. We work for you, and we don't know unless you tell us. So please feel free to call us if you have any questions whatsoever. And secondly, if you're going to Google responsibly. We all know that there's a lot of information out there, and we all search for information. So I just want to share with you to use credible sources of information. Your cancer treatment team, of course, the American Cancer Society, the National Cancer Institute, the cancer support community, other cancer-specific sites. Or if you're not quite sure and you type in something, make sure the sites end with .edu or .org or .gov, as they tend to have the most evidence-based and updated information available for you to research. Also, there are many apps that are available on the iPhone, so make sure that those apps are from credible services or as well. Sloan Kettering has a great app that's out there. The American Cancer Society Cancer Support Community Delaware has its own app as well. So make sure that you're using credible apps. And if you don't know, talk with your treatment team about what they would recommend. As I said several times before, your cancer support community is a great source of resource for you as well. Other local and national organizations, reach out to others. We're all here to help you, so we want to do what we can, so please let us know. And I just want to thank you for your time today, and I look forward to when we all can connect in person once again. Thank you, and have a great day, everyone.